we will start our morning program. I'm honored to call Dr. Tahan Ghamdi. She is Head Section Women Imaging, King Abdullah Medical City, Mecca. And she will talk about anesthesia perspective on ultrasound. This is very interesting subject and the new terminology for the last 3 years or 4, non-mass lesion.
Thank you. Thank you for coming early this day, and thank you, Almoosa, for gathering us up, breast imagers. It was amazing half day yesterday, and hopefully today will be the same, inshallah. Basically, I was very keen to talk about this thing because every time we get report, we get a very different descriptive terms. And some people, they easily can point out that these descriptive terms are not as good as what we're supposed to be. But definitely for the lexicon, we have specific things that we can follow. On the other hand, a few things that we cannot really follow. But there's nothing right or wrong because, there's nothing right or wrong when it comes to what to say, what not to say. The main rule, basically, it's miss no cancer, do no harm, right? So up to recent, this non-mass lesion is not something can be descriptive in the lexicon, but in 3 months from now, inshallah, we are waiting and we are tuned for the new thing. Basically, our talk today is just about to be familiarized with the likely changes that inshallah will be coming soon by Bayrat's 6th edition. And expecting to just suggest the description of ultrasound in accordance with the expectations of the lexicon and correlating these findings on ultrasound that we called it non-mass with the other imaging modalities. So basically, if we're talking about what does that mean? Okay, it's defined as a discrete ecotexture alteration area. Actually, I used to say it's like an area of focal alteration. I used to say that, but other words, some people, they said you can say non-mass like. It's not the issue. That's why hopefully it will be legalized more. So it's basically distinct from any alteration area, distinct from adjacent parenchyma. That doesn't meet the criteria for nodule. It can be identifiable in 2 planes and may be visualized in single plane. Other terminology have been proposed that, definition that discrete findings distinctly different from normal tissue lacks margination of the mass and cannot be assigned to a specific shape. And again, it can be seen in 1 plane. Any subtle thing in different 2 planes and shouldn't be confused with heterogeneous dense breast. That's why we have to always compare right and left, different quadrants. And different imaging modalities, if that what we are seeing is something can be reproducible or can be similar to other imaging modality. Actually, on purpose, I attended SPI last year, 2024, where they first discussed the new lexicon. The first 20 minutes was, then at the RSNA, they mentioned this. Basically, in the RSNA, they talk about the 20 minutes first for the mammogram. Then this is Dr. Long mentioned that in the talk that it will be expected to be released by 2025. New lexicon, new construct. So that means more of standardized reports. So still in progress. Basically, the reason why they proposed this, high techniques, very sharp imaging, a lot of findings. So our lexicon should be met with the findings that we see. It's not just a mass anymore. No, there are a lot of things in between. So I would like to shed some effort. These efforts had been made, proposed since 2004, 14, 16. The Japanese breast and endocrine ultrasonography, all those people, they did a great job once a day. So they tried to standardize our reporting system. So really, I really feel like I must mention how those people, they made an effort. They tried to make some reports, like this is Almoosa and colleague. They mentioned how they can describe any non-mass lesion as ductal, non-ductal. They try to make it more concise. Then the Japan and Society of Electronics, Breast and Thyroid, they try to mention that even the abnormalities in ducts, they mention it as non-mass, hypoechoic areas in mammary glands, any distortion, multiple cysts. So it's like a large variation. And here we can see, oh, yeah, ilahi. Okay, so if we can consider looking to this paragraph, a lot of people, they proposed a lot of descriptive terms, which almost equivalent to what we say, that is not a mass. We are not talking about 3D space occupying mass. And here a lot of people, they try to keep the description. So these descriptive terms we are using in our reports, nothing right or wrong. We cannot say why those people mentioning that, especially that we are working actually in oncology centers, referral and tertiary hospitals. We face a lot of words have been made, but nothing wrong with it, right? So basically, if we were talking about the epidemiology of non-mass observation, basically in practice about 1 to 5.3%. It's like it's a quite considerable amount. And the most important thing, it's most of the times are benign results, 46 to 90% benign results from these observation, and the malignant is only about 10 to 54%, which can be invasive. So we are in a very, very great gray area. So now the only thing about our talk, we will be tuned for the new descriptive terms that we use. But at the moment, we can just, this is how I stuck to this since August 2024. I try to keep my reports whenever I see such observation in three descriptive terms. So we can be more concise, more reproducible in our reports, and the observations can be more correlating to our reports. So basically, whenever I see something like that, non-mass area, I would like first to look for the distribution. Are we talking about something confined to single area, like focal? Is it something more larger, regional, linear, or segmental? Segmental is like more of triangular. That's what it looks like when what it's called the Cooper's ligament appearance. The linear, more of like the ductal appearance. Then we kept commenting as anything on ultrasound, the echo pattern between hyper, hypo, and heterogeneous. And finally, the associated findings. Associated findings, all these are imaging, by the way, right? Associated findings, anytime that we see distortion with it, echogenic halo or rind, as now we're using, shadowing, calcifications, or ductal extension. So all these should be comment whenever we are seeing non-mass enhancement. So, and the most important thing is the clinical perspective. If we see something, is that something is real? Is that something correlating to the patient's symptoms? I mean, if there's a palpable thing at that corresponding area, is there a nipple discharge? And is that something can be seen or correlated to another imaging modality on MRI or mammogram? So these are the imaging and the clinical point of views needs to be considered. So we can go through a few cases as an exercise, how we try to standardize our reporting when it comes to non-mass lesion. So here we can say this looks like an area of more focality, confined to a small area. It's like more focal. I used to say, altered echogenicity is like something really I cannot put a hand on. So this is definitely a non-mass area. Echo pattern heterogeneous, nothing associated with it. On mammogram, basically, we cannot see something can be correlated to this area. So this is a biopsy-proven PASH. So even PASH, no need to have like a well-defined mass. It can look like something like that. Again, this is another benign thing. It looks very ugly area. Again, non-mass lesion. It had a more of segmental distribution with distortion and shadowing. So like we are talking about something a bit looks ugly, but definitely it's not a mass. It has a correlate on mammogram and MRI. We can see it on mammogram and MRI. And had been sampled and a clip was placed. This is how it looks. And basically, despite how ugly it looks, it's patch. Here again, one of the very subtle findings on ultrasound that we can say, that we can see a very subtle shadowing. I'm sorry, will you use me now? It's a very subtle shadowing. Really, you cannot say if this is something that is it like a mass or not, but basically in two planes. So this is make it more genuine abnormality that we can see this in two planes. So we can describe it as something focal, hypoechoic, and some distortion maybe. On mammogram, definitely there is a correlate, small area here at the lower hemisphere. So basically benign biopsy-proven fibrosclerosis of the stroma. And then another spectrum for such a lesion, when we see when we saw something like that, we really we don't know, are we talking about the whole area here or the tiny area? But basically this is large area, nothing similar to the breast parenchyma. So basically it's a segmental as distribution and heterogeneous when it comes to echo pattern. Mammogram at the same area, basically some calcifications present. It doesn't look ugly. It doesn't look right. It's ugly appearing. MRI, non-mass area, biopsy-proven DCIS. And here, one of the examples of non-mass lesion on ultrasound, very subtle thing, but definitely there is some, sorry. Yeah. It looks very subtle thing. If we go through our exercise here, the echo pattern, we talk about hypoechoic. Distribution is focal, probably. Associated findings, basically calcifications, we cannot really comment on this on ultrasound, but basically on mammogram, it is present, and some distortion. And we can see some tethering here on fat parenchymal interface on mammogram. It has a correlate on MRI. So basically this biopsy-proven invasive lobular cancer. These are our references, not much really, but definitely a lot of people who proposed great review articles so they can legalize our reporting system. So we have to be more standardized and miss no cancer, do no harm. This is the basic thing. And inshallah, maybe in 3 months from now, our talks will be very different when it comes to such a finding. Thank you.
In addition to the clinical imaging of women, she has an interest in healthcare quality, patient experience, patient cancer awareness, medical ethics, and she holds a Master of Science in the Health Economic, and she also holds a certificate in healthcare safety and quality. Thank you for being here, Dr. Khoury.
That was very long. Thank you. Thank you first of all for the introduction, Dr. Like Dr. mentioned, I do have some background in health policy, which is kind of where I'm gonna take you, which direction I'm gonna take you in this talk. So let's get started. And the topic is basically how to use behavioral science to increase patient compliance with mammography screening. Disclosure statement. So in the beginning, we're going to talk about what is behavioral science and how can it influence healthcare outcomes. Then I'm going to review some theoretical frameworks that we can use to understand and predict women's behavior when it comes to mammography screening. I'm going to discuss nudge theory, which is a hot topic. Maybe some of you have been familiar with it already. And then at the end, I'm going to shift gears and talk a little bit about marketing and how to use marketing to improve, compliance with mammo. So what is behavioral science? Basically, behavioral science is a systematic interdisciplinary study of human behavior. And we draw knowledge from many fields, including psychology, sociology, economics, law, etc. The aim is to understand human behavior and how cognitive, emotional, and social factors actually drive human decisions. So humans are not logical beings. We don't do our decisions based on logic. There's a lot of bias. There's a lot of preconceived notions, a lot of emotions, a lot of environmental factors that influence how we make decisions. And this is kind of, the point of this talk. Some theoretical frameworks. So there's a very old framework where basically when it comes to healthy behavior or encouraging, for example, mammography screening, there's a very famous model called the health belief model. And this basically tells you that people's willingness to change their health depends on their beliefs related to health. And so there are several factors which are listed there, and you can see how all of them lead to likelihood of health behavior, which is likelihood of undergoing mammo screening in our case. So in terms of self-efficacy, you see that in the top right, or left, radiology left. That's basically the patient's faith in their own ability to engage in the healthy behavior. So in terms of mammo screening, it's the woman's belief, like, does she feel confident enough that she's going to do the mammography screening? And so for the perceived threats, perceived severities, perceived susceptibility, that is the point of the educational awareness campaigns, right? We educate the woman on the severity, the susceptibility, etc. Also the benefits, perceived benefits, we educate. For perceived barriers, that's basically, if the woman thinks, for example, I have a barrier, I have fear of radiation, for example, then we can work on targeting that fear by, for example, telling her the radiation level is very low, etc. So that kind of has to do with education, but also ensuring that our service is also good, and we address her fears basically. Cues to action is basically what is the trigger that finally triggers the woman to do the screening. So she has all of these things that she's thinking about, but there's something that happens that triggers her to do the mammo screening. For example, this can be an advertisement. It can be a doctor telling her, she's due. It could be someone dying in her family, and then, that triggers her to do it. So, all of these are things that we target during our awareness campaign. But I want to focus on self-efficacy. So how do we encourage self-efficacy in a woman? There are certain techniques we can use. For example, creating a checklist. Rather than saying, go get your mammogram, we create a checklist for her. So she does all the different steps, and when she accomplishes each step, that encourages her to do the next step. So it just gives her more confidence, more momentum. Another thing we can do is a virtual tour. So if we have a new mammo facility, we invite the women to come just look at the facility. Don't do anything, just come, have a look, meet the techs, look at the machines, etc. So this is just like a walk-in kind of experience. So then the woman feels more comfortable, more confident. Oh, I can do this. I can actually do the screening. Social modeling. So for example, creating advertisements where you present a woman who's relatable to that woman. So not necessarily a celebrity, but like a woman that's similar to the population of women that you're targeting. And you can start with, for example, the fear, like, oh, I thought that I wouldn't have time to do it, but it turns out that, I did it so fast. It was so smooth. I would really recommend this. And this is very powerful for women because a lot of them have specific fears. Sometimes women are nervous. So you can have like an advertisement of a woman saying, oh, I was really nervous during the, before coming in, but everyone worked to make me feel at ease. And then, so that all encourages the woman. It encourages her to actually do the screening. Throughout our journey, throughout the healthcare journey, you want to also give a lot of verbal support. So messages of empowerment to the woman, you did such a good job. I really applaud you for prioritizing your health. I know you're busy. Thank you for taking time for yourself, things like that. So that all encourages her. And then finally, you manage anxiety related to specific fears. So if she has a fear of pain, for example, you educate her, you tell her, for example, there is some discomfort with mammography, but it only lasts a few seconds. And, that kind of helps. This is a nice study that was done actually in Saudi Arabia. I just mentioned it because I thought it was very relevant. So they basically measured self-efficacy. There are different psychological scales that they used. And they basically tied it to breast cancer fear. So it's a very interesting article. It's coming from psychology people. Transtheoretical model. This is another model. So this model tells you that people to basically undergo a certain do a certain healthy behavior, in our case, screening, people go through different stages of readiness. So in the pre-contemplation, I don't know if does it work? Yeah, I don't know if you can see my laser. So pre-contemplation, the red part, 40% of people are in that category. So those are people who are not ready. They're not ready. They're like, I don't need screening. I don't have a family history. I'm healthy. I'm not going to do it. I'm okay. So 40%. And then contemplation is basically when you start saying like, oh, well, there's pros and cons. And you start weighing pros and cons. Like pros, yeah, I would like to have peace of mind. Cons, I'm worried about pain and I have anxiety, for example. And again, 40% of people usually are in that category as well. Then there's the green part is preparation. So they take an initial step. So they schedule the appointment, for example, and 20% are in that category. And then, of course, action is where they do the mammogram. Maintenance is when they come back the next year or in 2 years. So our goal is to design interventions at each stage for people of different stages in a way that it helps them progress to the next stage without relapsing back into the prior stage. So for example, something you can do for the pre-contemplation people, you can say, of course, education, you raise awareness, you give very emotional, dramatic stories to motivate them. Women in their contemplation, who are weighing the pros and cons. Again, our goal is to tip the balance of pros to the pros where she's actually pushed to do the behavior. So for example, if the woman's worried about radiation, like I said, you tell her, well, the radiation is very low, that's nothing to worry about, etc. So that kind of pushes her toward preparation. Now, in preparation, of course, patients have already taken the step. So for example, they've already called to schedule the appointment. So in this phase, we want to reduce barriers. We want to make it even easier. So we train, for example, the clerks to handle phone calls. We optimize Google search, for example. So anyone who's taken the initial step, it'll be more easier to go into the action phase. Now, when the women come to the action part, we want to make sure that she has an amazing patient experience, make sure everything is great, because we want her to maintain, we want her to come back. And again, we want to motivate her. We want to congratulate her. We say, great, you did your mammogram. That's wonderful, etc. Maintenance is, of course, having reminders, etc., to reward consistency. Now, I want to move on to nudge theory. So nudge theory is actually, again, a very famous behavioral science model, which has been used in many different sectors, including healthcare. So the idea is basically we want to provide an indirect suggestion or a visible cue that can influence a person's decision. And this can be sometimes as effective or even more effective than actually telling them what to do. So one very famous example, and I'm sure a lot of you maybe have seen this already. So in the cafeteria or in the supermarket, they will place the fruits more easily accessible than the candies. They'll put the candies somewhere else. So they're not going to tell you don't eat candy, but you'll see the fruit, and then that's a visual cue to eat healthier. And this has actually been proven to work. I just showed an example of Homer Simpson here. He's lazy. He doesn't want to go get the candy. He'll see the fruit. He'll get the fruit. So nudge theory is also, the idea behind it is basically there are two systems in your brain. There's system one, which is the intuitive system. It's experience, emotional, impulsive, like I want to act now immediately. I look at short-term wins. And this we use a lot. Actually, most of our everyday decisions are based on this. System two is the slow, deliberate, rational, logical, evidence-based, conscious decision. So for example, system one can be, oh, I want to get this very expensive item. I'm going to buy it now. System two will be like, okay, I want to save money. So every month I'm going to make sure part of my salary goes to a savings account. I won't see the money, so I won't be tempted to act on system one and waste my money. That's another example. So our point, basically applying this to healthcare, is to design interventions that take advantage of system one and system two in a way that the patient acts more in a healthy way. So I'll show you an example. So for example, using default appointments. So rather than telling the woman, schedule your mammogram, we will call her and say, oh, your mammogram has already been scheduled for this date. Does it work for you? Okay, if not, you can change it, for example, to make it more automated. Making the instructions very simplified. So rather than giving a patient like a detailed paragraph on how to take a medicine, you show them pictures. Make it very, very simple. Like, okay, this is what you do. And this also works as well. Social proof. So we compare the woman to other women in her area or her group of peers. So we say, for example, 9 out of 10 women in your age or in your area already did their mammogram. It's your turn now. And this helps the woman feel that the behavior is common, it's acceptable, it's approved. So she's more motivated to do the behavior. Then there's something called reframing the message. So rather than saying getting a mammogram will detect breast cancer early, you say, if you don't get a mammogram, you will miss the chance to find breast cancer and you may lose your life or your breast. And this is because loss, a fear of loss is more powerful than a gain for a lot of people, most people. So make it about losing rather than gaining. And that works as well. You can have timely prompts. So for example, in the US, every time it's the woman's birthday, because they do it annually, they do breast screening annually, every time it's her birthday, they call and say, happy birthday, time to do your mammogram. And so that kind of reminds her, and they tie the birthday with getting a mammogram. Another thing you can do is commitment devices. So for example, we have a sign-up sheet. We have an event, we have a sign-up sheet, sign up for your mammogram. Signing or writing is like taking a pledge. So she's more motivated to do something because she's already made a commitment. This is showing kind of a ladder. They call it the ladder of nudge interventions. So as you go up, the patient has less choice. So it becomes more automated, more commanding. And then at the bottom is basically like the nudges, soft nudges, indirect signals, and then going toward up is more forceful. And different strategies work at different levels, basically. This is what it's saying. Nudge theory can also be applied to referring physicians. So in Qatar, for example, we have a big problem of like referring doctors not referring women for mammography, because maybe they forget or maybe they're not aware or whatever it is. So one example of using nudge theory is to have an automated alert every time the doctor opens the EMR for a woman, even if she's coming for an unrelated reason or whatever, the GP, whoever, they get an alert that says, oh, this woman is above 45, you know, order a mammogram, for example. And that helps make it much more automated. I'll shift gears now and talk about marketing. I know this doesn't make sense maybe because marketing, you know, it's all like business, but people have shown that, you know, business strategies actually work in healthcare in terms of getting patients. So it's the same idea. So in marketing, we have something called STP, segmentation, targeting, positioning. And I'll explain what this means. So in the beginning, you have a service or you have some product or whatever it is. You want to segment the market. So you want to divide the market into smaller groups of different customers, in our case, different patients. And different patients have different needs and characteristics. Then you target, which means you select the groups that you want to focus on. And then positioning basically means sending a message to that group or different groups that helps each group kind of pick you as a brand or pick you as a service. So I'll explain using an example. So segmentation, you can do it different ways. For example, you can segment it based on age. So we can do younger women versus older women. We can do it based on income, insurance, education level, etc., working versus non-working. So you can imagine different women have different needs, different concerns, different fears, you know, all of these things. Then you have like psychographic. So for example, you can segment the market in terms of health conscious women, very proactive about their health, versus like anxious avoider, like they don't want to do anything. Behavioral. So for example, you can say behavioral status, a woman who's never been screened versus a lapsed user versus a regular adherent or a proactive woman. And then readiness stages, like as I mentioned with the trans-theoretical model, people are at different stages. So you can segment the market based on who's in that category of readiness. So here's an example. So let's say we want to do it behaviorally. We want to segment the market using behavioral segmentation. So we want to segment the market into behaviorally distinct groups. So we do, for example, women who have never been screened, then lapsed users who have already been screened, but now they're overdue, so they're avoiding their mammogram. And then you have regular adherents or women who always come. And then we look at, what do these groups want? Is it accuracy? Is it speed? Is it convenience? Is it comfort, cost effectiveness, etc.? So then we decide which group we're going to prioritize. So let's say I want to focus on the anxious avoider. So this is the women in their early 40s, those with high anxiety, and they have a lot of concerns about pain, results, etc. Why do I care about this group? Because if I can gain their trust, they can have I'll basically gain long-term loyalty and also in the Arab world we know that younger women get cancers younger than in the West, so this is kind of maybe one of your targets. And then maybe lapsed users, they've had the mammogram before, but now they're just kind of delaying getting the repeat. And then early adopter is like, okay, she's already health conscious. I don't really need to focus that much on her. But this just shows you a way to prioritize different patients and then design your marketing strategy for each. So here's an example of how do you position your message or positioning statements. So for the anxious avoider, we focus on comfort. We say, we understand your concern. We want to give you peace of mind. And we basically focus a lot on comfort and same-day results. So, she's not very nervous. Lapsed user, this woman, she's already been in the system. She's done it before. So she just needs a small nudge, a reminder, or we offer, for example, evening clinic or whatever she needs to get it done. Maybe she's busy. Early adopter, maybe she's focused on technology. So we'll tailor our message to focus on technology. We say, for example, don't just get a mammogram, get the clearest picture with our state-of-the-art technology, because that's something that she's looking for. In conclusion, undergoing mammography screening is a complex decision, and women do not make decisions or take actions based on logical means. Behavioral science concepts and frameworks can be used to understand the needs of different women and also design interventions that encourage mammography adherence. Nudge interventions aim to redesign the environment to make the healthy behavior easier. And basic principles of marketing give us the capability to shift from a one-size-fits-all to a more effective patient-centric strategy. Thank you.
Thank you, Dr. Mariam, my dear friend, for the warm presence. Thank you. It's really a pleasure to be here again. After this distinguished summit, after last year's remarkable events. Thank you, Dr. Mustafa, Dr. Suzanne, Dr. Samra, for having me. My talk today about fat necrosis. Fat necrosis, no conflict of interest. Also, fat necrosis known as a great mimicker. In literature, it's the most lesions that mimic and confuse us with malignancy. So is it our talk today is to interpret fat necrosis and distinguish it from malignancy? No. Our talk today is about how to develop the skills to determine which lesion to biopsy and which not to biopsy or do unnecessary intervention, especially that, as we know, a large population of this category of patients are already had a harsh journey of surgery, radiotherapy, so you don't want to do extra unnecessary intervention. Like this patient, she had her annual surveillance after 2 years of left nipple-sparing mastectomy, where these non-mass enhancements shown in the contralateral breast. And actually, it was correlated with these group of linear distributed microcalcification. So is it a DCIS, contralateral, is it a fat necrosis? So remember this case, and this will be discussed at the end of our talk. Let's go to the basics. What's fat necrosis? Any vascular insult causes what's called tissue necrosis, fat saponification. This is lead to another phase with non-suppurative inflammation, and late we have this scarring, fibrosis. However, these stages are not that clear as this. It's overlapping in staging at times. So with overlapping in pathology level, this means also overlap in all our radiology features across different modality and across time. So it's always like I see this new microcalcification, this uptake of FGG. Okay, this is recurrence. Then you are assured when it's by time it's coarse calcification. Then oops, I see a mass with shadowing, and then you correlate with other modality. It's a rim of calcifications that shows shadowing. So it's always like this, right? So this is the challenge of fat necrosis, the too many phases of fat necrosis. So what can we do is have some tips for reaching to our intuition of how suspicious we are. I categorize based on the etiology. Main etiology of fat necrosis is either trauma or all the surgery and the intervention, and I put the cosmetic in a different category. For trauma, let's see. For example, this patient came for a palpable lump. I think the radiologist asked her, do you think there was a trauma? Usually any female will say, yeah, I had a trauma, I had something. Because he said he sees this kind of cystic lesion with internal echogenicity, no posterior shadowing. So it was reported as hematoma as a precursor of fat necrosis. Even more, the radiologist jump into the fat necrosis of resolving hematoma. Unfortunately, after a few months, the patient came back with locally advanced mucinous invasive ductal carcinoma. What happened here? That we should not reach the conclusion, not jump to the conclusion without enough evidence. Our bridge is to have enough evidence to reach the conclusion, not to jump. Many literature mentions that the most lesions that radiologists always jump to the conclusion are fat necrosis, because of anyone say trauma, and galactosile for any patient say I'm breastfeeding. So before we jump to conclusion, we have to get solid feature. For example, this patient also had a history of trauma, but when I inspect her, there is a bluish bruises, the discoloration on the overlying skin. The hematoma is superficial location. There's no vascularity, hyperechoic rim, and there is anechoic center, concentric evolution, which is typical for hematoma, which is different than the first case. So our question today is biopsy or not to biopsy. This is the question. For this first case, I didn't have enough evidence, and I'm sure if the Doppler was there, they will show a vascular margins and concentric evolution in the center, not in the periphery. Margins is irregular. So this is where I decide that this lesion should be biopsy and I should have suspicious, and this one not to biopsy. Second category. So teaching points is like having the clinical context. Sometimes the blunt trauma is superficial. Sometimes the seat belt distribution is more like a track distribution. The clinical typical imaging features that match with the time of the trauma and the stage. Lipofilling, the cosmetic. Okay. This is a category that I hate. This is why if I find the lamp of Aladdin, my third wish will be dedicated for vanish all these cosmetic fat injection procedure, disappear. This will be one of my wishes because my life is difficult with this procedure. For example, this patient came with her husband and she was having these lumps and there was no history. As she said, did you have any history of intervention? She declined one time and I find this cyst with complex feature. Oops, it's a complex mass with solid component, and then I scan again, I find another one, and then I go to the other breast and I find similar. So this is where it's a lipofilling. It's very clear, but the patient keep declining. Okay, so because she's declining, I said, okay, I was very assured. So I told her, come back for follow-up. She came back for follow-up, and as you can see, the evolution of the fat, now it's more like hyperechogenic, and by 18 months, when she finally admit, she had this flattening, oblong, anechoic, typical for this evolution of fat necrosis. Do you encounter these patients as they keep? Yeah, they keep saying. So typically, fat necrosis, cystic, avascular, yes, even implant. They have implant and they decline. Evolution, flattening over time. All these are the bilaterality is a assuring sign, flattening, and of course, if you have the patient admit, sometimes you need to pressure the patient to admit that she has this cosmetic procedure. Other features on mammogram. Mammogram is the black horse in fat necrosis, and you can see these bilateral, multiple variable sized lucent with calcification, rim of calcification. It evolved over time, so it's more assuring over by time, typical rim of calcification. In MRI also shows the typical fat signal intensity in the center, and by the time even the capsular enhancement, it fades and not to progress. So these are the solid features for fat necrosis, for lipofilling. So biopsy or not to biopsy. Okay, we have two cases. And now tell me, this patient came with, she said that she has this autologous fat graft, fat injection, bilateral. She was doing her screening, and I think we were suspicious of this area in the left breast that shows some, you see this distortion in the bottom of the this one. We were some suspicious, despite that the lesion itself, it's a fat necrosis, but this distortion may be hidden inside. So we decide to do the MRI. And as you can see, there is a non-mass asymmetric, non-mass enhancement below the fat lobule. So at this point, okay, this is case number 2. We will discuss both. The case number 2, she had feel palpable hard lump in the right breast, and she has history of implant removal a couple of years ago. As you can see, this very distorted, irregular area with associated with microcalcification in the center of the right breast. In the ultrasound, it also doesn't seem like it's a non-mass or with shadowing posterior. We did the MRI, and on an MRI, you can see that there is fat filled with fat signal intensity in the center. On the other side, as you can see, there is also another one similar, which has bilobulated fat signal intensity. At this point, which case you biopsy and which case, oh, sorry, it's already not to biopsy. The first case, despite that this is fat locus, and you know that this is fat injection, however, it carries some suspicious features. So we decided to biopsy, and it came as a typical ductal hyperplasia, no malignancy. The second case, despite these pleomorph microcalcification, very scary features, but when you did the correlation with other modality at bilateral fat signal intensity lesion, you decided not to biopsy. This is the thing, not to everything, even when I'm sure this is, but it has the features that worth to biopsy. Last category is the, of course, the surgical post-intervention, any intervention in the breast. The first case, do you still remember? The case with contralateral non-mass enhancement with these microcalcifications. At this point, it was very suspicious, right? But we decided to add one more step, magnification view. When we did the magnification view, it's now, is it more clear now that these calcifications are part of the curvilinear wall of the oil cyst, which correlate to this cluster of cysts at the same area. And this is very important that always fat necrosis need to complete all the workup, all the correlation with other modalities that possible. So in this case, despite it was very suspicious, now it's very clear that it's a fat necrosis oil cyst. So for a post-intervention biopsy, complete your workup and always look for the site of the, if it's concordant with the procedure or not. For example, reduction is always in the inferior, like this case, like this past case. If you notice, this case had had reduction mammoplasty. You can see from the nipple level and from the traction of the parenchyma upward, this reduction mammoplasty. So it's this location is concordant with calcification fat necrosis at this area. On the other hand, the previous case with removed the implant, it's always typical to have these changes fat necrosis in the center at the muscle. Flap are always peripheral fat necrosis and the calcification. So, for example, this is a typical site for reduction mammoplasty in the inferior breast, and this is for the implant replacement. So, which one to biopsy and which I will show you two cases again, and you will say which to biopsy and which. Case one. Which one?
Yeah, here. About
This was fat necrosis. It was fat necrosis. No, it wasn't biopsy, but it was 2 years of follow-up. And now it's more obvious that it's a fat necrosis. I will. Yeah, she has 2 years of radio. She has 2 years of follow-up, and it's all around this cluster of fat necrosis of oil cyst and fat necrosis. I will send you the follow-up. It's more now like having more like a center of fat now. I should put it here. Okay, and so these two cases are cases post at the mastectomy or lumpectomy site where there is these dense masses with capsule of enhancement. This is in the upper at the tail of the breast, and the other case, it's like similar that it has also a cavity with ring mass enhancement in the posterior breast, and this was reported as the first time as seroma cavity. However, in the if you look back to the MRI at this time, it wasn't fulfill all the signal intensity of fat necrosis in all the sequence. This is why after a year, when she came back, it was obvious that this was not a cavity or fat necrosis. It was a recurrence. So in these two cases, what's the difference? Why here it's not need to biopsy, and why here should be biopsied from the first time we saw it? I think first the site, as we were speaking, go back always to the initial cancer and look at the site of the cancer. Where was it? This one was inferior, and it's not common to have the fat necrosis in the inferior breast lumpectomy always, and the dissection maybe in the tail. So this one was at the site of the previous cancer, and it didn't fulfill all the signal intensity in all the MRI sequences. So this should be biopsy from first place, and this not to biopsy, and this was proved to be a cavity with fat necrosis. So in post-intervention, as we said, complete your workup, concord the site, the procedure, look at the initial cancer location and the typical signal intensity on all MRI sequences. And I have another two cases because this is important category of patient, recurrence versus fat necrosis. The first case, the surgeon palpable these two nodules, felt this nodule after nipple sparing mastectomy, and she finished already her radiotherapy. So the surgeon was quite suspicious. We did the ultrasound, and you can see this nodule had these echogenics in the center. So and emotionally, the patient was very frustrated. Yeah, like to tell her again that she will need more imaging, more intervention. She was really that day very frustrated. So at this point, we said, yeah, it's echogenic, no vascularity inside. It's fat necrosis nodule. However, because as we said, we didn't complete our workup. It's a few months, and it's grow fast, and it's turned to be a recurrence. So this is another example of fat necrosis, especially complete all the workup, correlate with all modality you can do. On other hand, this case is the opposite. She had this seroma cavity and these coarse calcifications that sure for that it's a benign place. When she came on 2023, we were just looking ultrasound to check the seroma. And at this point, we see this area inside the seroma that doesn't seem collection. It seems more like a solid mass with calcifications. And it's a like report case. It's a recurrence inside the seroma cavity. When we complete the workup, we find, yes, a solid lesion. And on FDG, as you can see, it's uptakes the FDG, so it's a recurrence. So this is the difference between two cases that you complete all the workup you can do versus you just assumed, because sometimes the patient is very frustrated. So take home message, our approach in fat necrosis, intermodality correlation combined with concordant clinical context. Our green light is to collect sufficient evidence of feature and concordant with the time and site of the insult. And our red flag, which will always make us not sure that finding across modality, any conflict across modality or even in the same modality like MRI, not matching all in the sequences, interval progression, location are not the original insult of cancer. And our ultimate goal in fat necrosis is always to develop the skills to balance between avoiding unnecessary procedure while not to miss a cancer or recurrence. Thank you so much. And I'm inviting you all to Cairo in January as a big international conference of breast and gynae oncology that's held every year. We will be happy to have you all. It's all a specialty, all international speakers from everywhere. Thank you so much and have a happy Pink October. Thank you.